Hello, guys. Welcome back to Easy Medicine. The topic that we're going to discuss today is bronchial asthma. The bronchial asthma is a chronic inflammatory disease of airways where there is airway hyperresponsiveness to endogenous or exogenous stimuli, and there is reversible bronchospasm because of this. And this reversible bronchospasm will result in the airflow limitation. The bronchospasm and this airflow limitation here in bronchial asthma is reversible, whereas there is a significant irreversible portion in chronic obstructive pulmonary airway disease. This is also an obstructive lung disease. In contrast to chronic obstructive pulmonary disease, here the obstruction is reversible. And in chronic obstructive pulmonary disease, there is permanent damage to the alveolar wall as well, but here there is no alveolar damage. There is only chronic reversible inflammation of the airways. Now, let's start with the risk factors of bronchial asthma. There are multiple risk factors. Let's just briefly review them. So, starting with the genetic risk factors, the presence of genes like ADAM33, DPP10, and OMDL3 genes may increase the risk of bronchial asthma in certain patients. Patients with atopy, that is associated diseases like allergic rhinitis or eczema, can increase the risk of asthma. Allergens like house dust mites, animal fur, cockroaches can also increase the risk of asthma. Occupational exposure to certain gases like carbon monoxide, nitrous oxide, and sulfur dioxide can also increase. Infections like viruses and mycoplasma infections have also been incriminated in the development of bronchial asthma. Tobacco exposure, obesity. The obesity will increase the production of adipokines and leukotrienes like IL-6, and then diet which is poor in omega-3 fatty acids but rich in omega-6 fatty acids, reduced levels of vitamin C, A and D, and reduced levels of magnesium, reduced levels of selenium, and high levels of sodium. All of these also are incriminated in the risk factors of asthma. And certain fungi can trigger an allergic airway mycosis like allergic bronchopulmonary aspergillosis like diseases. And then we have the high intensity exercise can also trigger in elite athletes. There is a disease called as the acute irritants or reactive airway dysfunction syndrome. The acronym is RADS. RADS stands for reactive airway dysfunction syndrome. This can also be a cause. And pregnancy, there is increased risk for bronchial asthma. And in the newborns, for whom the maternal age is low at the time of birth and there is late breastfeeding for the child, the child born with prematurity or low birth weight, and the usage of proton pump inhibitors and H2 blockers by the mother while the child is in the womb can also increase the risk of bronchial asthma. So this is an exhaustive list of the risk factors for developing bronchial asthma. And after that, we'll also have to look at the triggers. I know this is a little bit boring and exhaustive, but still we may have to, at least we need to have the idea of which can result, which are the risk factors for the development of bronchial asthma and which are the triggers for it. Again, the triggers are viral infections and mycoplasma related respiratory tract infections, allergens like house dust mites, animal fur, and cockroaches, irritants like strong odors and smoke, air pollution with sulfur dioxide, nitrous oxide, and carbon monoxide, drugs like beta blockers, aspirin, and AC inhibitors. These are to be avoided in a patient of bronchial asthma. And hormonal changes like pregnancy, perimenstrual, as well as perimenopausal period can also increase the risk of episodes of bronchial asthma. And exercise, cold, dry air can trigger bronchial asthma. Presence of GERD can also trigger an episode of bronchial asthma. Right? So these are the risk factors and triggers. Now let's look at classification and pathophysiology. Mainly, the bronchial asthma can be because of either eosinophils or because of neutrophils. When it is because of eosinophils, we call it as type 2 inflammation. So based on the kind of inflammation itself, the bronchial asthma has been classified as a type 2 inflammation or a non-type 2 inflammation. The type 2 inflammation is predominantly by the eosinophils, and it is also called as the atopic or extrinsic type because the extrinsic type here, the allergens which are located in the environment are the cause for the development of this eosinophilic inflammation. That is why it is called as extrinsic. So the eosinophils are the cells which are predominant cells here, and the eosinophils will produce interleukins 4, 5, and 13, and these are primarily going to mediate the pathogenesis in this type 2 inflammation. And the eosinophil related inflammation everywhere in the body is extremely steroid responsive, be it this bronchial asthma, be it the uh, allergic bronchopulmonary aspergillosis or Churg-Strauss syndrome in rheumatology, all of these are having predominant eosinophilic inflammation, and all of them are very much responsive to steroids. Then non-type T inflammation. Non-type T inflammation is where there is no extrinsic allergen. Inflammation is happening inside the body because of the predominating neutrophils. This is a non-atopic or an intrinsic type because there is no extrinsic allergen or the environmental allergen which is triggering this bronchial asthma. And this kind of inflammation is mainly predominated by the presence of neutrophils, and the interleukins which are produced here are the IL-6, 17, 8 and TNF alpha. These are the interleukins which predominate in non-type 2 inflammation, and this is also steroid resistant. The eosinophil mediated inflammation is very much steroid responsive, but neutrophilic inflammation is steroid resistant, and this is also associated with chronic infections like mycoplasma. So these are the brief differences between the type 2 and non-type 2 inflammation. Now let's look at the type 2 process. So here is the bronchial wall, the smooth muscle, and above which you can appreciate the mucus and the columnar epithelium with the goblet cells. Initially, there is an antigen. The presence of antigen will trigger the T helper 2 cell. The T helper 2 cell will produce this interleukins IL-13, IL-4 and IL-5. 4, 5 and 13 are the important interleukins which are produced here. IL-13 will increase the production of mucus from the goblet cells. Whereas on the other hand, IL-4 will attract the B cells here, and the B cells will further produce IgE. IgE mediated mast cell activation will result in the production of histamine, leukotrienes, and other interleukins, which further result in the bronchial smooth muscle hypertrophy, hyperplasia, and bronchial smooth muscle hyperresponsiveness, where the bronchial muscle vasoconstriction will happen because of this. And on the other hand, we have IL-5 as well. IL-5 attract the eosinophils. IL-5 is a eosinophil chemoattractant, and the eosinophil will again result in the same effect, that is a smooth muscle hypertrophy, hyperplasia, and increased responsiveness of the bronchial smooth muscles. So this is about the pathogenesis. So when there is a normal airway, as you can appreciate, the lumen here is quite big, and the mucus layer is also quite thin in a normal airway. But in an asthmatic airway, the mucus layer has become reasonably thicker. There is also the mucus, the smooth muscle hypertrophy and hyperplasia that you can see. This is a relaxed asthmatic airway, but still the lumen is significantly compromised. When there is an asthmatic airway during an acute asthmatic attack, you can appreciate the thickness of the mucus layer is significantly increased, and there is bronchoconstriction as well because of increased hyperreactivity, right? And here you can appreciate the smooth muscles are relaxed in the normal airway as well as an asthmatic airway when there is no significant bronchoconstriction or when the patient is not having an acute attack. And this is the state when the patient's bronchial smooth muscles are constricted. Now let's look at the clinical features. So when you talk about the symptoms, mostly the patients will have productive cough because of the excessive sputum should go out, right? It is not purulent. So this is a productive cough with usually a whitish sputum, and the patient can also complain of chest tightness, wheezing because of reduced airway or because of this airflow limitation, and obviously the patient will also have shortness of breath. The shortness of breath may awaken the patient at night, and it will also get exacerbated with exercise. So this is an exacerbating factor. And signs. The signs that you commonly can see are the tachypnea with increased respiratory rate because the patient is in distress. That is why the patient breathes harder. And there is tachycardia associated with it. And in very severe bronchial asthma, only then you can appreciate pulsus paradoxus. It is not seen in every case. When the patient is having severe asthmatic episode, that's when you see pulsus paradoxus. We discussed about this pulsus paradoxus when we spoke about cardiology and pericardial diseases. Hope you can go there and refer what is pulsus paradoxus and how does the patient develop pulsus paradoxus. In severe bronchial asthma, what happens? The hyperinflation of both the lungs from both the sides are going to compress onto the heart, and when the right ventricle tries to receive the blood, it will not be able to relax and expand more because of the restriction overlaid by the lungs which are located. And since the right ventricle is not able to expand outwards, it will push the interventricular septum towards the left side. And when the interventricular septum is pushed towards the left side, the LV preload is reduced. When the LV preload is reduced, systolic blood pressure will be reduced. SBP falls by more than 10 millimeters of mercury. That is pulsus paradoxus seen in cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy, and it can be seen in here as well. Then wheeze which is usually polyphonic. Polyphonic in the sense it can be heard in both inspiration as well as an expiration, and there is prolonged phase of exhalation. Exhalation is, when you compare it with the inspiration, the exhalation is prolonged here. Then let's look at the diagnosis. The diagnosis, see, this is a chronic inflammatory disease. You will not be able to appreciate any crepitations here, unlike COPD, where in COPD there is alveolar destruction and alveolar wall is also digested because of the protease antiprotease mismatch. But here the alveoli are okay. Only it is a disease of airways. That is why you will not be able to hear any other adventitious sounds. And this requires the main characteristic feature of bronchial asthma is reversible airflow limitation. The airflow limitation and its reversibility can be only proven with the help of pulmonary function tests. So this is a PFD based diagnosis if you want to confirm. So the obstruction and reversibility needs to be proven with the pulmonary function tests. So when you initially test for the FEV1 and FEV1 by FVC ratio, the FEV1 is less than 80% and FEV1 by FVC ratio is less than 0.7. And you can also appreciate, if you keep on checking the peak expiratory flow rate variability, it will be varying between the day to night also. It will be varying between different times during the day also. So there is a variability of more than 20% from day to day or from morning to evening, either spontaneously or with the treatment. Okay, so there is a peak expiratory flow rate variability of more than 20% day to day or in the same day. And when you look at the DLCO, diffusion lung capacity for carbon monoxide, this is normal or slightly increased. What is the reason? First of all, DLCO is reduced in chronic obstructive pulmonary disease because the airway is damaged, and also the perfusion barrier, the alveolar wall at which the oxygen and carbon dioxide exchange happens, is also significantly damaged, and it is replaced with fibrosis, which makes it incapable of transfer of gases, right? So here the alveolar barrier or the perfusion barrier is normal, and hence the DLCO is also normal. Sometimes it is also increased because of the reason that chronic inflammation can also increase the production of vascularity inside the lungs, which may increase the uh, lung capacity for absorption of carbon monoxide and associated and other gases as well. So DLCO is normal or slightly elevated in these patients. Then now you have proven airflow limitation. The next step is to look at the reversibility. Is it really reversible? For that, you will give a bronchodilator. So bronchodilator response test, give short acting beta agonists like salbutamol or albuterol. What you can observe is a 10% change in FEV1 or FVC from the baseline related to the predicted. That is what you can appreciate. And FEV1 can also increase by more than 12% or 200 ml in absolute terms. Okay, so increase in FEV1 by 12% or 200 ml can also identify it as reversibility. Third one is a bronchial provocation test. Now we have a normal airway. If the patient is not having recently an episode, you want to trigger the patient to develop an episode of bronchial asthma. So what do you want to give? You can use metacolin or histamine, hypertonic saline nebulization or mannitol. Even cold dry air and exercise can also trigger bronchial asthma. So you have noted what are the triggers, and you are just trying to trigger an episode of bronchial asthma in an otherwise stable patient, if you want, because we want to check for the hyper responsiveness of the bronchial airway. So when you give this any kind of trigger that we have mentioned, the FEV1 will drop by more than 20% with methacholine and more than 10% with the others. If above 3 are inconclusive, then the last step would be to do fractional expiration of nitric oxide. So here the eosinophils are the predominant cells in most of the cases. So the eosinophils will produce nitric oxide. So that is why if you look at the fractional expiration of nitric oxide from the exhaled air, the nitric oxide content is increased. So this is increased because this correlates with the sputum eosinophilic levels. The eosinophils produce nitric oxide, and the eosinophilic inflammation is very responsive to steroids as well. So when the patient is on steroids, when the patient is continuously using the treatment, that is inhalational corticosteroids, the nitric oxide levels will be suppressed. So when the levels are low, that indicates good response or good adherence to inhalational corticosteroids. But if the nitric oxide levels are increased, it means that the patient is not getting treated properly, and if the patient could be having a poor adherence to the usage of inhaled corticosteroids. These could be the reasons for the increased levels of nitric oxide in the patient. So what have we done till now? So we have done a pulmonary function test. By looking at that, we have identified whether there is airflow limitation or not. The second step would be to look at the airway responsiveness to bronchodilator. If the bronchodilator increases the FEV1, then it means that there is some response. It could be a reversibility. Then third one is bronchial provocation test, where you are checking for the airway hyperresponsiveness by giving some kind of trigger in the form of either methacholine or histamine or cold dry air or mannitol. And lastly, we can also do the fractional expression of nitric oxide, which will help you in identifying whether the patient is strictly adherent to the inhaled corticosteroids or whether the patient is not adherent to the corticosteroids. Then we have the allergy testing. Allergy testing is to identify to which allergen is the patient sensitive and which allergen is triggering an episode of bronchial asthma. So that can be identified by doing a skin prick testing. Sorry, or RAST, radio allergosorbent test. And you can also test the IgE for specific antigens. A specific IgE testing may also be done. Then the blood tests like complete blood picture will show you increased eosinophilia that will indicate good response to interleukin 5 therapy. And serum IgE levels are also increased. When they are increased by more than 1000 international units per ml, then you should think about allergic bronchopulmonary aspergillosis. Okay, the serum IgE, when it is increased more than 1000 international units per ml, then evaluate for allergic bronchopulmonary aspergillosis. Then what are you going to do? You are going to look at the aspergillus specific IgE levels. Okay, and this is also helpful for calculating the anti-IgE dose, that is omalizumab. And when you look at the chest X-ray may be normal because in an earlier stage there may not be significant hyperinflation of the lung fields. There can only be airflow limitation, but as the episodes keep on coming during the progression of the disease, there can be development of hyperinflation of lung fields as well. That's when you can see increased dark shadows on a chest X-ray. Now let's look at the arterial blood gas analysis. The arterial blood gas analysis will show whether the patient is having a type 1 respiratory failure or a type 2 respiratory failure and how severe is this asthmatic exacerbation. So at an asthmatic attack, firstly, because of airflow limitation, the patient will have hypoxemia. The hypoxemia is PaO2 less than 60 millimeters of mercury. Because of this hypoxemia, the peripheral chemoreceptors, which are carotid bodies, gets activated, and further the respiratory centers in the medulla will increase the respiratory rate. So the patient will have tachypnea and hyperventilation. Hyperventilation will result in the carbon dioxide washout, and the patient will have hypocapnia. So with hypoxemia and a normal or low PaCO2, this is called as type 1 respiratory failure. But with gradual progression of this disease, if the patient is not treated immediately, the patient may land in muscle fatigue. So with muscle fatigue, the patient will not be even able to hyperventilate, and PaCO2 keeps on accumulating inside the patient. So with hyperventilation, the patient will eventually develop hypercapnia with a PaCO2 of more than 45 millimeters of mercury, and the patient will land up in type 2 respiratory failure. So at any level, the patient can be there. So this is identified with the help of an ABG. Now let's look at the management. We have brought this image back from the pathophysiology just for making our understanding easier. So we are going to block this pathophysiology at multiple levels. Let's start with the mast cell stabilizer. The mast cell stabilizer is going to prevent the degranulation of the mast cell granules, thereby reducing the release of histamine, leukotrienes, and interleukins. When the histamines are produced, we have antihistaminics which are going to block the histamine receptors. Then we have leukotriene receptor antagonists. Again, they are going to block the leukotriene receptors. Then we have the bronchial muscle dilators or bronchodilators, namely beta agonists and the muscarinic antagonists. These two groups of drugs are the bronchodilators that can be used here. And eosinophilic inflammation is very responsive to anti-inflammatory drugs like the corticosteroids. Then an anti-IgE monoclonal antibody, omalizumab, can be used. We have the anti-IL-4 antibody, which is dupilumab. Then anti-IL-5 antibodies, mepolizumab and reslizumab. We have an IL-5 receptor antibody, that is a benralizumab. And lastly, to reduce the responsiveness to a particular antigen, we can do HDM slit. HDM slit stands for house dust mite sublingual antigen immunotherapy. So you are giving immunotherapy to the patient and increasing the tolerance to the exposure to the antigen. Now let's look at the drugs deeply. Let's start with the corticosteroids. The corticosteroids that we can use in a patient of bronchial asthma can be inhaled corticosteroids or oral corticosteroids. In severe cases, we can also use intravenous corticosteroids. The inhaled corticosteroids, they will reduce the type 2 inflammation and reduce the airway responsiveness. The common drugs that we use under this inhaled corticosteroids are budesonide and mometasone. What are the side effects? The side effects are oral thrush or dysphonia and hoarseness of voice. The oral thrush is nothing but oral candidiasis because of the deposition of corticosteroid drug in the oral cavity. Dysphonia and hoarseness is also because of the corticosteroid drug which is depositing on the vocal cord, and that will get irritated. Okay, so if you want to prevent these complications, you want to prevent the delivery of the drug in the oral cavity, deposition of drug in the oral cavity and pharynx. That is why, as shown in the image, here is a spacer. So what you want to use? You want to use a metered dose inhaler with spacer, and you want to gargle the oral cavity after you inhale the drug. Okay. So as shown in the image, here is the spacer and here is the metered dose inhaler. The spacer will prevent the deposition of drug in the oral cavity and the pharynx, whereas the metered dose inhaler will help in the delivery of the particular dose of the drug. And oral corticosteroids can also be used. What we commonly use is prednisolone, and it has the systemic, all the systemic side effects of huge load of side effects are there for corticosteroids, right? So we have multiple systemic side effects of corticosteroids, and an important complication is pneumocystis pneumonia. Okay, so these are about the corticosteroids that we use. Then the next group of drugs are the leukotriene modifiers. Leukotriene modifiers can be leukotriene receptor antagonists and leukotriene synthesis inhibitors. So the leukotriene modifier drugs, they will inhibit the production of leukotrienes. This is leukotriene synthesizing inhibitor. Okay, that is xylitol. And we have the leukotriene receptor antagonists, which are montelukast and zafirlukast. Eventually, reducing the effect of leukotrienes will reduce the airway hyperresponsiveness. The drugs that we use are montelukast and zafirlukast. These are LTRA, and the leukotriene synthesis inhibitor is xylitol. The side effects are depression, sometimes suicidal ideation for these drugs. Then we have the mast cell stabilizers. These drugs will reduce the mast cell degranulation, and the common drugs that we use are the cromolyn sodium. Then we have bronchodilators. The bronchodilators that we commonly use are short-acting or long-acting beta agonists and muscarinic antagonists. The short-acting beta agonists are salbutamol, terbutaline, and albuterol. The mechanism of action will be beta 2 receptor activation will result in the cyclic AMP mediated bronchodilation, and the drugs are salbutamol, terbutaline, albuterol. And the side effects are hypokalemia, hyperglycemia. Of course, okay. The long-acting beta agonists that we commonly use are salmeterol and formoterol. The side effects are hypokalemia, hyperglycemia, tremors, tachycardia, hypertension, and the monotherapy should not be used because usage of monotherapy for a longer period of times will reduce the eventual effect on the bronchodilation, and the patient will have increased exacerbations and increased mortality. That is why we stopped using monotherapy of short-acting beta agonists or long-acting beta agonists. We only use these drugs in combination with inhaled corticosteroids in the patients of bronchial asthma. Then long-acting muscarinic antagonists. Long-acting muscarinic antagonists, they are going to inhibit the cholinergic receptor and further result in bronchodilation. The commonly used drug is tiotropium, and the side effect is dry mouth because it is a anticholinergic. And the next group of drugs are the phosphodiesterase inhibitors. These are also the xanthine derivatives. Methyltheophylline, etophylline, and aminophylline are the drugs which are included here. And these drugs, they are also going to increase the cyclic AMP mediated bronchodilation. Cyclic AMP mediated bronchodilation. And the drugs are theophylline, etophylline, and aminophylline, which is a combination of theophylline and ethylene diamine. The side effects, these drugs are rarely used now because of this narrow therapeutic index. Now, what are the biologics or monoclonal antibodies that we are using here? The omalizumab is an anti-IgE antibody and it is given subcutaneously. Mepolizumab is an anti-IL-5 antibody again given subcutaneously. This can be given at home. Restylizumab is an anti-IL-5 antibody. This is given intravenously. And then benralizumab, this is an anti-IL-5 receptor monoclonal antibody. This can also be given at home subcutaneously. Then we have dupilumab, which is an anti-IL-4 and IL-13 antibody. This is also given subcutaneously at home. So these are all the monoclonal antibodies that can be used in the management of bronchial asthma after the usage of all the above drugs. Next, let's look at the global initiative for bronchial asthma management. Firstly, let's grade the bronchial asthma into intermittent, mild persistent, moderate persistent, and severe persistent bronchial asthma. This is based on the symptoms and how frequent are they. Is there any night awakening and what is the level of FEV1? So it is called as intermittent when the symptoms are 2 or less days, if the patient is symptomatic for 2 or less days per week, and if the patient has symptoms 2 or less nights per month, at least 2 or less nights per month, and FEV1 is normal or it is more than 80%. In mild persistent, the symptoms may be present for more than 2 days per week. Night awakenings will be more than 2 nights per month, and FEV1 will be normal here as well. In moderate persistent cases, the symptoms may be seen daily. So in mild persistent, we have seen more than 2 days in a week, and in moderate persistent cases, the symptoms are seen daily, and the night awakenings are at least one per night per week, at least one night per week. And the FEV1 is usually in the range of 60 to 80%. And in severe persistent cases, the symptoms are present all throughout the day, and the night awakenings are seen every night, and FEV1 is less than 60%. So this is about the grading of bronchial asthma. So depending upon this grading, we'll also manage the cases. So in the management, we have a controller and then a reliever. The controller is going to reverse the pathology, and the reliever is going to relieve the acute symptoms that the patient may be having with an acute asthmatic episode. So what are these? The controller that we commonly use is low dose inhaled corticosteroid with formoterol. Like I said, we don't use the bronchodilators alone, we always use them in combination with the bronchodilator, which is a short acting or a long acting beta agonist, preferably long acting beta agonist. So we initially start with low dose inhaled corticosteroid with formoterol as needed, because the patient is also having symptoms intermittently. Only then, when the patient is having symptoms, only then you will use low dose ICS with formoterol. Then when the patient is having mild persistent bronchial asthma, here as well you will use low dose inhaled corticosteroid in combination with formoterol as needed, but here you will use leukotriene receptor antagonist, and you can also add the house dustamide sublingual immunotherapy. HDM slit can be an add-on controller. In a moderate persistent case, you will use low dose ICS formoterol daily. Starting with the moderate persistent case, you start using the inhaled corticosteroid and formoterol daily, and you can use the add-on controllers, which are LTRA, HDM slit, and occasionally high dose inhaled corticosteroid. And in severe persistent cases, you can use moderate dose ICS with formoterol daily. You can also use add-on controllers LTRA, HDM slit, and high dose inhaled corticosteroids. Then even if the patient is not responding to these treatments as well, then you can use high dose inhaled corticosteroids with formoterol daily, and the add-on controllers can be long acting muscarinic antagonists, oral corticosteroids, azithromycin, and biologics further. So we'll gradually escalate the levels of treatment as we move from the intermittent to the more severe cases. And reliever can be an inhaled corticosteroid with formoterol, or inhaled corticosteroid with short-acting beta agonist, or short-acting beta agonist alone as required only when you require relieving of symptoms with an acute exacerbation. Otherwise, we'll put the patient on controller itself. Now, how do you want to treat an exacerbation of bronchial asthma, otherwise called as severe acute asthma? So firstly, when you look at the patient sits in a tripod position similar to that of a patient seen in severe COPD. So patient sits in a tripod position. Because of tachypnea, the patient will not be able to complete its ascent also. the patient will be only able to talk in a few words. He is agitated and irritable because of this, and the respiratory rate will be more than 30 per minute. That is what the patient is tachypnic, and with tachypnea there is also tachycardia, pulse rate of more than 120 beats per minute. With severe acute asthma and hyperventilation, the patient will have the pulsus paradoxus. The oxygen saturation is less than 90%, and the accessory muscles will be clearly visible that the patient will be using accessory muscles for hyperventilating, and peak expiratory flow rate is less than 50% of predicted. The peak expiratory flow is less than 50% of predicted. Now, this is how the patient will be in a phase of severe acute asthma. Then how will you treat them? Initially, start the patient on short-acting beta agonist with muscarinic antagonist as well. The patient could be already on an inhaled corticosteroid. The inhaled corticosteroid is not going to bring an immediate change. It is a controller, not a reliever. So start with the reliever, and of course, since the patient is also having desaturation, give the patient oxygen support. Try to target a saturation of 93 to 95%, and if required, you can give a high dose inhaled corticosteroid. You can also give intravenous corticosteroids here like hydrocortisone as well. So oral or intravenous corticosteroids can also be given. And lastly, intravenous magnesium can also be considered in the management of severe acute asthma. If the patient is going to land up in imminent respiratory failure or respiratory arrest, the patient could be having hypercapnia and the patient will be drowsy. The muscles are fatigued, there is hypercapnia, and the patient is drowsy. Instead of hyperventilation in an acute severe asthma, the patient is drowsy now. That's when you'll have to do mechanical intubation. Intubation and put the patient on mechanical ventilation, assist control mechanical ventilation. If there are exercise induced symptoms, the exercise induced symptoms is because of the epithelial injury. As soon as there is epithelial injury, there is recruitment of mast cells and the mast cells degranulate, that will result in bronchoconstriction, right? And the treatment will be, if the patient is doing only occasional exercise, before the exercise he can take ICS formoterol combination. If the patient keeps on doing regular exercise daily, then they keep the patient on maintenance LTRA, daily LTRA. But if the patient is having a sudden episode, then you can give reliever with ICS formoterol or ICS SABA. Anything can be used as a reliever if the patient suddenly lands up in an episode of bronchial asthma. What are the drugs to be avoided? You want to prevent the drugs that trigger bronchial asthma. What are they? Beta blockers, because they'll result in bronchoconstriction. You also want to prevent the usage of AC inhibitors because it can also trigger dry cough in certain patients. And aspirin and NSAIDs, because most of the patients can be aspirin sensitive. You want to avoid the usage of these three drugs in a patient of bronchial asthma. There is an entity called as AERD, otherwise called as the aspirin exacerbated respiratory disease. The word itself is telling you the patient gets this episode of bronchial asthma with the usage of drugs like aspirin. So this is also a type 2 inflammation with eosinophilia. When there is eosinophilia, it is corticosteroid responsive. There is a specific triad called as Samter's triad. It is a triad of asthma, sinusitis with recurrent nasal polyps, and aspirin intolerance. See, the aspirin, the name of aspirin is, the other name for aspirin is acetyl salicylic acid, ASA. So remember the same by for remembering the Samter's triad. A for asthma, S for sinusitis with nasal polyposis, and A for aspirin intolerance. This is together forms the Samter's triad. And then sometimes the patient can also have rhinorrhea and conjunctival irritation because of this eosinophilic inflammation. And the treatment would be avoid non-selective COX inhibitors. Why? I'll tell you. We should not use COX inhibitor because the non-selective COX inhibition will result in increasing the production of leukotrienes. Okay, so there are two pathways, COX pathway, another one is a LOX pathway. I'll show you. The COX-2 inhibitor can be used. This is not a non-selective COX inhibitor. We can use a selective COX-2 inhibitor. Inhaled corticosteroids and leukotriene modifiers can be used in the management. Even IL-4 and IL-5 biologics are also useful. So how are they useful? The arachidonic acid can be metabolized through COX or LOX pathway. The COX pathway will result in the production of prostaglandins, and the LOX pathway will result in the production of leukotrienes. So if you use the non-selective COX inhibitors, this entire right pathway is gone, and all the arachidonic acid will be transferring to a pathway where there is excessive production of leukotrienes that can trigger this episode of bronchial asthma. So you can use selective COX-2 inhibitors where the entire COX pathway is not blocked, and hence the leukotrienes will be at their low levels. Hope you understood this. So this is all about the bronchial asthma. Hope you like this explanation. Hope you like this video. Please share and subscribe this video to your friends and follow this channel. Thank you.